Hello, everyone. Welcome to another interview another interview for PCR Online from the ESC Congress in Amsterdam. Today, we are having the pleasure to welcome Dr. Kang and Dr. Park, the principal and the co-principal investigator of the OCTIVUS trial, which compares the intravascular ultrasound guided PCI and versus the OCT guided PCI. Welcome, Dr. Park. Welcome, Dr. Kang.
Thank you for inviting us.
And it's a pleasure to have you here with us. Let me directly jump to my first question. What are the main take-home messages from the OCTIVUS trial?
Okay, thank you for inviting this wonderful, interview session. If I'm gonna summarize the take-home message of our OCTIVUS trial, this is a pragmatic trial. Include this diverse coronary arterial region in your daily PCI practice. We try to include the complex PCI region. And the key message and the OCT guided PCI was non-inferior to IVUS guided PCI in measure the clinical outcome of the target vessel failure at 1 year. That is our key message.
Thank you so much. Dr. Kang, would you like to add something on this?
Oh, yes. The most important thing is that we already know that especially in complex PCI subset, intravascular imaging guidance has some benefit over the angiographic guidance PCI. And we have two devices, majorly OCT and IVUS. And we previously had very small data of the comparing two devices on the clinical outcome. The OCTIVUS trial compared two devices in respect of the clinical outcome in sufficiently large amount of the patient.
Yeah.
So it confirms the non-inferiority of the OCT compared to conventional IVUS guided PCI.
And now the OCT guided PCI, we can easily say that is non-inferior to IVUS guided PCI in patients with a diverse coronary anatomy, I guess.
Yeah, absolutely.
My second question is, I think it's a really important question for me as well to hear from you the answer. How do you decide between the OCT guided PCI and the IVUS guided PCI in your daily practice?
So I think that is question from the David D. Park at the hotline session 4 in the half of patient the raise up hand in the IVUS, half of patient the raise up of the hand OCT. I think in the practical point in our cath lab, previously we routinely use IVUS for the guided PCI, but I think on the basis of OCTIVUS trial, October trial, Illumine trial, we can use anyone on your practice, on your preference. I think two device would be okay, and so depending on your choice, you can choose each one.
Thank you.
And one another important thing is the very low event rate on the OCTIVUS trial. That we think that because we used intravascular imaging, and then patient outcome would be better and excellent with any devices. And what I practically recommend is that you can use anything that you are familiar and you can do your best.
Yeah, I think this is a great conclusion.
Yeah.
Thank you. And the other question I'm wondering is, when it comes to angiographic success, your rates are great. But when it comes to IVUS guided or the OCT guided procedural success, which are defined with a predefined criteria, the success rates lower. And even with OCT guided PCI, there is a significance between the OCT guided procedural success and the IVUS guided procedural success. How do you explain these findings from your study?
So I think our Dr. Kang Do-Yoon is responsible for coherence measurement. He can give a right answer. Okay, Dr. Kang?
Please.
Okay, there are several reasons it can be. And first would be that the two different devices undergo two different approach. Usually in OCT guided PCI, we use the lumen-based approach. And in IVUS guided PCI, many use vessel-related the approach, and that first can make some difference in lumen area. And However, in QCA analysis, the final MSA was not different between groups. However, the MSA by imaging, by OCT or IVUS was different. There can be another explanation, and that the OCT is known to make the lumen very clear cut and measures the clear lumen size. However, because of the character of the ultrasound, IVUS usually measures a little bit larger in the OPUS class or other phantom studies. That can be another explanation. And lastly, and third, the OCT showed higher rate of the malposition or large dissections. However, that would originate from that where better visualization of the stent and the lumens. So we can find more dissection, more malposition. However, it was not correlated with the clinical outcomes. Yeah.
Thank you so much. Would you like to add something?
Yeah. So the one of the important issue about is how can it follow the common sense about the recommendation. What is imaging criteria? Yeah. In our trial, in the protocol we followed EA PCI expert documentation is usually a reference vessel more than stent expansion more than 80%, no major dissection, blah blah blah. But that is, I think, still arbitrary recommendation, and we need a further study. What is the best cutoff value, best optimization criteria? And looking at the several data, and in terms of MSA, most of data just achieved the 50% of stent optimization criteria. So the reason that we require further study to define the practically and importantly, we apply what is the stent optimization criteria would be next the further research.
And with the in the OCT guided PCI group in your study, I believe the minimal stent area MSA was around 5.6,
yes.
right?
Yeah.
It's a bit different from our general practice.
Yeah.
So I think you really did a great job. Thank you so much for your contribution to the field, to the PCR Online for this interview. And again, I want to congratulate you for the results of your study. Thank you.
Thank you.
This is the end of our interview, and please stay tuned for the next episodes of the PCR Online interviews from the ESC Congress from Amsterdam. Thank you so much.
Thank you so
Thank
much.
you. Bye.